going to jump right into it. Just maybe give me a quick chat or a thumbs up if you can hear me. Just want to make sure that the audio is working well. Great, thanks, Michelle. And I'm just going to pull up my PowerPoint slide here. Thank you, Suzanne. Good. Give me one more thumbs up so you guys can see my screen here, and we'll get started. Great. And Dana, I think I see you on there. If you can help me maybe allow some people to enter the room. It's hard for me to do both. You're able to do that. We'll try to through here. But welcome. This is our first ever eeBeyond seminar. And we will be talking about eeBeyond medicine and semaglutide. Everybody pronounces it a little bit differently, but I pronounce it semaglutide. Some pronounce it semaglutide. But a very hot and interesting diabetes and weight loss medication. We'll get more into that. I'm Dr. Stephen Dahmer. I am a board certified family physician, medical director as of recently at eeBeyond Medicine. I've been with the team here for almost 6 years, but was working in other areas and now have taken on this role full time. So you will be seeing my face more often. We certainly hope to do more of these in the future, bridging that gap between what we're learning on a daily basis and interacting with patients and all the knowledge that each and every one of you have. And so I'm very excited that you guys all joined. I've been giving lectures for a long time, and I usually quiz participants if they know where the word doctor comes from. My understanding is it comes from the Latin docere, which means to teach. So I love doing things like this and kind of bridging that gap as much as possible. Here's the disclaimer. While some of you on this call, I might be your physician, I'm not acting as that right now. This is general information. And any decision, right? And this is anything that we watch or listen to, really any decision that we make should be made in confidence with our provider, physician, nurse practitioner, PA, really bouncing off source information to our specific nuanced case with everything that's related to our own. eeBeyond seminar, I'm kind of making this up as I go. And so hopefully this goes smoothly, and we hope to do more of these, but establish a regular discussion on key topics related to health for our patients. This is kind of the goal of these seminars, is to bring up these hot topics and share with you our knowledge and expertise, and even practical knowledge as we're utilizing some of these things on a daily basis with patients. Let's close that gap between science and practice. And many of you that are my patients have heard me say that science sits here, and there are some estimates there's a 15-year gap between what's on the forefront of science and what actually comes through my family medicine journals. And so what we're constantly doing is trying to bridge that gap, but not in a way that puts our patients at risk or might increase harm. Share insights on new topics. Today's discussion will be semaglutide. I am going to mix in there a couple more things about functional and integrative medicine, as I will always do. So hopefully in the future, you guys won't get annoyed by me always coming back to integrative and functional medicine, and then answer questions and allow for discussion. We have had a number of great questions come through that I'll probably jump to first, and then we'll try to take a look at the chat. And apologize if I'm not looking at that as we're going through, but we'll try to peek at that later to answer any questions. First, a couple definitions. This is hard for me, and I've dedicated life to it. What is integrative? What is allopathic? A couple definitions. Functional medicine, systems biology-based approach. We're trying to identify and address root cause of disease, oftentimes on a micronutrient, molecular, right, vitamin and mineral level. Integrative medicine is what I was originally, in addition to allopathic medicine, is a healing-oriented medicine that takes into account whole person, all aspects of lifestyle, and emphasizes that therapeutic relationship, right? Shared decision-making between the provider and the patient, informed by all evidence, and makes appropriate of all therapies, right? It's not just Eastern or Western or Ayurvedic or fill in the blank. It really is looking at as many modalities as possible and trying to find the best evidence, whether they work for that patient in front of us or not. And allopathic medicine, maybe a little unfair definition I gave allopathic medicine. I am an allopathic physician. I am board certified. My training was in allopathic medicine. It is a system in which doctors and other healthcare professionals, nurses, pharmacists, therapists treat symptoms and diseases using drugs, radiation, and therapy. We certainly do some prevention, usually by way of vaccines, small amounts of nutrition. So there is stuff on the prevention side. But I do argue, that I'm supposed to be a primary physician. Little of what we do in modern medicine is primary care. Sorry about that. We're getting a couple messages through here. That's my life is kind of messages through Teams these days. So, lifestyle, integrative medicine, we know this, and yet it's probably one of the hardest things we face. I've honestly faced this for 20 years as a primary care physician, but following a healthy lifestyle may prevent over 80% cases of coronary artery disease, 50% of ischemic strokes, 80% of sudden cardiac deaths, 72% of premature deaths related to heart disease. These numbers, for someone that loves numbers, that's myself, are staggering. And yet it's such a hard thing for each and every one of us to do. Very recently, and debated this quite a bit, and each kind of funnel or integrative have their own pillars, but we did use a little iteration and came up with the eeBeyond 7. And these are to mimic in that research, show those same numbers that I just showed you. What are the things that support that? Sustenance or food. Dana is kind of an expert here on the call and working with people in their nutrition and optimize that, put in their eat. I love like a practical takeaway for everything, right? And that's probably one of the main focuses among many others that we do in terms of nutrition. Movement, move it or lose it. Just had a discussion this morning, and some of you probably even heard that exercise is effective as an antidepressant, right? In terms of mild to moderate depression, just so key to move. Sleep, just a huge aspect, and we'll circle back to this because our discussion today will be about healthy weight. Sleep is absolutely one of those pillars of healthy weight, and sometimes we try to address that even on that first visit because it's so important. Nature and sunlight, obviously all of us are aware of vitamin D, and even just the healing potential of nature. Stress, probably the Achilles heel of each and every one of us on this call. From our phones constantly going off to the demands of our work, sometimes coupled with family or friends. And it just is something that we face on a daily basis and try to engage in our interaction with patients as well. Social and epidemic of loneliness, right? We're really facing that, and isolation caused by COVID has made that even worse. And it's an absolute key aspect of health. And spirit, right? To be very frank, one we usually don't always get to, but could be in some cases with patients, probably the most important thing that we talk about. But I just wanted to introduce the eeBeyond 7 for everyone that's a patient at our clinic. Hopefully you'll be seeing this more often. And our handout has a little bit of a challenge. Can you identify maybe one that is one of your weaker pillars, and can we do something to address that? So let's jump into nutrition and weight and healthy weight. And for me, when I first started exploring obesity medicine, when I first started exploring weight loss medicine, I was really amazed at the incredibly high percentage of patients that lose weight and regain it. And it just really is something that we don't talk about enough. And so again, always applaud the amazing work that we do when we lose weight, but many of you have probably heard me say as well too, what are we doing to ensure that it stays off? And this will be something I hope we keep coming back to. I want to put this on here because a study I just listened to this morning about The Biggest Loser, I think many of you have probably seen that show or heard of that show, where there was weight loss to the tune of 100 plus pounds, really remarkable. But what the study in follow-up almost 14 years later showed that we have to be careful in terms of the acceleration of that weight loss. If you remember, this was a competition to try to get those numbers as low as possible. What that showed is if we lost too fast, right, which we're all kind of eager to do, just to be honest, do that too fast and undue stress to the body, it can reset our metabolic clock, in a way that fight against us even 15 years later. Not speaking too much doctor talk, but in short, we want those quick weight loss, occur. You have to look for the long game. I think it's really important that we have our eye on that. And the other thing I put on here is that the evidence is now overwhelming that there are physical changes in weight regulating pathways that make it difficult. And again, it's for a long time, even in my career early on in med school, it's someone's fault, right? That they didn't have enough willpower, or they weren't making right decisions, why they had too much weight. And I'm very relieved that we're getting to the point that that's not the truth. And the truth is that there's a really deep embedded metabolic change, sometimes mixed with genetics and certainly mixed with lifestyle, to yo-yo or to have such trouble losing that weight. And so let's move from the kind of crux. Here on one hand, I'm telling you life is king, right? But then with weight, wow, there's a struggle here. And this is just really, I think, an awesome example of medicine. Certain things will help, but then we have certain issues that we need a little bit more help, and enter semaglutide. And what has been this kind of considered a weight loss miracle. And anytime I hear the word miracle, I do get a sense of hype, and I want to take that with caution, because there's usually some truth to that, and there is some criticism, which we'll get into. But first of all, what is it, right? It's this class of GLP, glucagon-like peptide 1 agonist. And the first one that was approved for clinical use was exenatide in 1992. And I did find this very curious that it was isolated originally from lizard venom. I think I promised some people that they'd walk away at least learning something. And it's still, nature is oftentimes the source of many drugs, including this amazing new class of GLP-1s that came from lizard venom. But I also like to reflect, it's not that long that it's been around, right? 1992, for many of us, is not too long ago. So it is a newer molecule. Glucagon-like peptide is a 30 amino acid peptide hormone. It's produced in the intestinal cells, so right in our gut by these L cells. And, I do have a inkling, right? A stronger belief that these peptides are a very interesting therapy. These short chains of amino acid, we find on a much more basic level that still interact with the human body in a way that the human body can still utilize checks and balances, natural checks and balances that it has for things not to go overboard or to cause too much. And again, that's a blanket statement, but I'm very curious with peptide therapy, because I do believe it allows in many ways for that body's natural check and balances to keep it from creating too bad of a side effect. The semaglutide, right, and I think you'll see that right here in the middle, also called Ozempic and Wegovy, right, is one of a large group of medications. So there are many of these one agonist, really differentiated one between injected and non-injected. Rybelsus is the only one that's oral, you can take by mouth and not to have inject. And then long-acting and short-acting, right? The longer acting you can inject once a week. The shorter acting you have to inject often. But this is a whole class of medications in which there are many. Question front and center from patients, Wegovy and semaglutide and Ozempic, what's the difference between these? And, again, and now I'm in semaglutide, generally, semaglutide, we might consider, like the generic form of a medication, but for all fits and purposes, they are the same, right? And even in the pharmaceutical world, between a brand name and a generic is usually just the precision by which that formulation has to occur. Meaning if it states it as 5 milligrams, it has to be more precise within that 5 milligram target. Many of you, maybe not many of you, but some of you also know that, wow, I just can't tolerate certain medication, and I can maybe the generic, or I can maybe the brand name. We do see that in practice. But again, the Wegovy, semaglutide, Ozempic are really the same medication. Really, the difference is kind of an FDA process and what are they approved for. And Wegovy specifically for overweight and obesity, and Ozempic specifically for type 2 diabetes. And really the difference is not even the medicine itself, but the titration schedule. And that means how quickly are we increasing the dose. And you'll see here kind of differing titration or increases for these two medications. Again, Wegovy more focused on overweight and obesity, Ozempic more focused on type 2 diabetes. But I would argue that these are interchangeable. And some of you might even, that maybe are already on semaglutide might say, wow, that's not the schedule that I'm on. There are literally probably 5 or 10 different schedules. And we have created our own schedule at eeBeyond Medicine based on patients' use and really monitoring side effects. What we're trying to do is maximize the positive impact of the medication, but minimize side effects. The side effects here in a second. I reminded myself I should slow down. It's tough when I don't do it and there are people in front of me, then I just kind of speed ahead and I want to make sure that I'm not going too fast. But I think a lot of these are very key information about this presentation, really wanted to get across. Again, for me, I always ask, how does a medicine, even a supplement, any therapy, what's the mechanism of action or how does it work? And I will state that, there are a lot of theories we don't exactly know, like many things in medicine, we don't like to admit this often, but how the GLP-1 drugs lead to weight loss, right? We do know that there are GLP, while they're made in the intestines, there are receptors in the brain, right? And I put kind of 3 areas of the brain where those receptors are located. And we do know that activating those receptors can do the following things on the right. Increase satiety. Satiety is a medical term that we feel full, right? And decreased hunger. Hunger, we all know what hunger is. And so right there in itself, we can see how that might contribute to weight loss. Decrease food cravings, increase food control. Some might argue by mechanism or by way of those top ones that it can improve or increase food control. Can change food preferences. So certain foods, might not be palatable or we might not have interest in. It slows down the movement of food from the stomach into the small intestines. When you slow down that movement, you're going to feel fuller for a longer period of time. Reduces sugar released from the liver and increases insulin production. Each of those that we know can have impact on weight loss, right, or maintaining healthy weight as well. But those are the main mechanisms of action by which this class of medications works. And again, any drug, there are certain people that it is not for, right? And I tried to highlight real big here some of those. We are fortunate that there aren't too many for semaglutide, and any one of us that's seen an ad for a drug on TV sees all the scary kind of things that can occur at the end. Any drug and even supplements and even strawberries run that risk of an anaphylactic reaction or these severe reactions. But we do know that the GLP class of drugs is not recommended if you have a personal or family history of a specific type of thyroid cancer or multiple endocrine neoplasia. And many patients are like, oh, what is that? You would know it if you've had it or if you do have it. Generally, it means that there is a strong family history of endocrine cancers in your family. And again, not everybody will know that. I guess I should say that to be clear. But generally, there's a constellation within your family specifically of endocrine cancers and thyroid most specifically. Lab studies have linked these drugs to thyroid tumors in rats. One of the biggest things that I realized in my career when I embraced fully research is what happens in a rat does not translate to a human. So we find many, many things that occur in rats that we cannot say they happen in humans, yet anyone is going to open their eye and say, okay, well, something's not good is happening in these rats. We should maybe be careful with this medication. And one of the things that many of the pharmaceutical companies will state, or even the FDA that approves these, we need to continue to monitor these. And that's the beauty of an FDA process, is that there is ongoing what we call post-market surveillance. So ongoing, is this something that may or may not occur in humans? And we don't suspect it will, but until more long-term studies are done, the full risk to humans is not completely known. And this is going to be true kind of any new substance, any new drug that comes down the pipeline. And this group of medications is also recommended if you have had pancreatitis. So how much, right? Let's get to business, Dr. Dahmer. How much weight will I lose? And again, this is one of many studies that have been done. Probably the one that's quoted the most. There's an average about 14-pound weight loss. And look, I think a couple key things to note on this is that 14.1 pounds is at a 2 milligram dose, right? So that is a higher dose. For those of you that are starting, we're starting at 0.25 milligrams. So we do have to get up to that dose of 2 milligrams. You can also see the baseline is 220 milligrams. So you have to take that, or 220 pounds. You have to take that into consideration at what your starting weight is. Lower doses, we won't see as much, but I've seen a lot of research that, as much as 50% of will lose up to 10% of their body weight. And many of us can do those calculations. I will share I'm 192 pounds. That's 19 pounds that I could potentially lose on the Ozempic. And looking at this timeline as well, many patients ask, well, how long will it take me to get there? This is looking at 40 weeks. How much does it cost, right? And again, it's something that we try not to deal with too much as physicians. I'd much rather spend my time speaking about your health, but yet we all know that this is yet potentially another stressor. Many insurances are refusing to cover new weight loss drugs. There was a recent Times article about this. Many on the call may have even faced this, and I can tell you it's kind of at times overwhelming for our team to go through prior authorizations to try to get these done. But it's no small amount the monthly price of these medications, and this is something to keep in mind, right, as we go on to this therapy, that there is a long-term cost, especially when not covered by medication, that we should be aware of. Side effects, most of the more common side effects do improve as we take the drug. So that is something to keep in mind. And we do reiterate with patients that also doesn't mean that you should be absolutely suffering, right, as you're going through this. And the most common, right, are gastrointestinal. So nausea, vomiting, diarrhea are probably our top three. We have seen, some cases of mild fatigue. We have seen some headache as well, and there's a whole list of potential side effects, but sometimes it's hard to, suss out as well, is it the medication or the other things that are occurring that could trigger some of these side effects we do see. Low blood sugar is the most serious potential risk, but we really have not seen that when used on its own, right? That's much more of a risk when patients are on other diabetes medications, specifically those that do lower blood sugar. So this is actually one of the things we like about these medications, like metformin. It won't cause hypoglycemia. And anyone that has felt or had hypoglycemia, it's really intense. Even in the hospital where I used to work, someone, when they have hypoglycemia in extreme stages, almost appears dead. And I don't use that term lightly, but you give sugar and right away they pop up. Short of that, really extreme side effects to low blood sugar that we don't want to trigger in patients. So it's reassuring that this doesn't cause that. So kind of, I try to put together just a slide. I mean, let's get to the nitty gritty. I mean, I sometimes joke that I want to be called a specialist in pragmatism, right? I think that's what we need a lot of times in medicine is, how does this translate to my life, doc? And what are the actual pros and cons? Pros, obviously front and center, remarkable efficacy in weight loss, 10, sometimes even 15% of weight. We saw the 14 pounds in the 4 weeks. Really without lifestyle changes. And that's pretty remarkable for many, many patients. That injection can be once weekly. So there's pretty easy, for those that are comfortable with injecting low blood sugar. There are some of these medicines have been linked to reduce CVD, which is heart disease, and also in NAFLD, which is fatty liver disease. And so, many patients that are struggling or trying to maintain a health, there are also considerations that we have to keep in mind. Downsides, right? Long-term treatment is needed. And again, it's most research that I've looked at, if we stop the medication, right? And this is a common question that we get, but if I stop this medication, what happens? The research to date that I've looked at is you can, without making those lifestyle modifications, can regain 2/3 of what is lost. So, wow, 10%, what a great number by just offering this injection once a week. I have to stay on this the rest of my life, or 6% of that could come back. Cost we discussed too. There are some concerns about gallbladder potential disease. I didn't put that in the other risk section, but this is something that we're still, sussing out. Long-term safety, right, as we just at least hinted on, is a question mark. Long-term efficacy is another question mark. Do we tolerance, right, to this. And there are a few things that I've come across in medical career that I don't develop tolerance to. And so that's a big question that's on my mind is how do we do over time? The pancreatitis, the thyroid cancer. And then finally, there is a lot of evidence that this institute or actually triggers microbiome effects, right? Microbiome changes. Some of the evidence actually shows that certain microbiome is associated with this drug with greater weight loss. And microbiomes, each and one of us have our own unique microbiome. That's the gut bacteria, right? The bacteria in our organisms. But not only impact the efficacy of the drug, but then there are concerns in certain integrative and functional circles. Well, what about, is there a detrimental effect to our microbiome long-term when utilizing this medication? And then I come back, right? And so we talked about this, sledgehammer, very interesting, incredibly efficacious, therapy and weight loss that many people are excited about, including doctors. We're recommending much more. We're trying to utilize a lot more in our practice. This is where me the beauty of integrative and functional medicine comes in. In many cases, and Dana, maybe you'll get a chance to share some of these as well, where we'll have marked weight loss with our integrative approach, right? And I put here the contributors to healthy weight, good nutrition, adequate sleep, which is just absolutely key. I don't think that we touch on that enough. For anyone recently read a study that a single light in your room at night can contribute to weight gain. Seems remarkable and unbelievable. I'm going to now have to look up that reference for those that are going to want that. But sleep is absolutely key in maintaining healthy weight. Certain supplements and herbs that we utilize in our practice, obviously exercise and movement. I say to all of my patients, exercise and movement probably won't move the needle a ton on weight loss. Number one factor in preventing the yo-yo that I discussed earlier. So any patient that's looking to maintain a healthier weight, we need to find something that we're excited and passionate about, that we move, right? And I, again, say a minimum 10,000 steps and shooting for at least 5 days a week. Acupuncture, hypnosis, mindful eating, stress management, all of these, I think, play a huge role in maintaining a healthy weight long-term. And then obviously the weight loss program, where it might include GLP-1s. And there are a number of other medications we routinely use in maintaining a healthy weight or in weight loss. We do a full evaluation, not only of everything feeding into this healthy weight on this slide, medications that might promote weight gain, looking outside the box in a full lab profile as we do with our patients, a functional medicine profile, even looking at microbiome specifically, things that might contribute to weight gain or fight against weight loss for patients that are looking to go that direction. And this is just, for me, has been kind of my revelation for time and why I'm sitting here in this seat right now. I was trained in Western or allopathic medicine, and in many ways, this is what we were as a mechanic, right? You come in and you have a reflux, and I got a reflux drug, right? You have high blood pressure, I got a blood pressure drug. You have an appendicitis, and I have a surgeon that will take that out, and we replace and we fix and we intervene, and the human body is modular. And I have nothing against that. I really don't want to come across as such. And I think that it is remarkable in acute care medicine. If I have a pneumonia, I want an antibiotic. I want to treat that pneumonia with an antibiotic. If I unfortunately break my hip, I want to go to the best orthopedic surgeon and have that replaced. These fall short in chronic diseases. Chronic diseases is much more challenging. It's much more multifactorial. It's incredibly nuanced to that person in front of me. And that's where I see a paradigm shift occurring, and I'm happy to participate in, where we're no longer a mechanic and I'm just going to give you a GLP-1 agonist. That is not the whole picture. We need to really support a patient in those many factors going into weight, get the right conditions for a healthy weight to continue in the future. The soil, the sunlight, the nutrition, you guys all know what that analogy would be for us as humans, but the same is true for plants. That would be true for us as humans. We need those right conditions and those right resources and inputs for us to truly live a healthy life. And Lawrence LeShan wrote a fantastic book, I think this was even in the 60s, where it first kind of called out that mechanic versus gardener. And someone else has to fix a machine, but given the right conditions, that plant can heal itself. And one last slide here, just it's a big thing that, Occidental or Western or allopathic medicine and integrative medicine or functional medicine or holistic medicine, these are not enemies. These are not mutually exclusive. And I think each side has really tremendous things to learn from one another. And I'll be honest, in my career, I'm seeing an absolute blending. 20 years ago, being called integrative, people, kind of raise their eyebrow and wonder what's going on. And now, some of the major institutions all have an integrative medicine department. Memorial Sloan Kettering, Mayo Clinic, all have integrative medicine departments. So we're seeing this change quite a bit. And a quick plug, just recently instituted, some of you on the call may even have been bothered by this from me. We recently paired with Outcome MD, where we are actually going to be, taking in data from our patients. And the goal is not to bother you guys with a lot of questions, but are there objective ways for us to monitor progress, right? Most important for me as a physician is a patient looking me in the eye, I feel better, doc, or obviously we can see weight go down. But this is a way to look at questionnaires that have been validated by research, right? Questionnaires that really reflect what we're trying to look at, whether that's quality of life or chronic pain or an anxiety scale, that we can share with you. You can take under 5 minutes to fill out. You can truly monitor progress over time. And for me, one of the biggest things about being a physician is really come. And I think this has been one of the most challenging things for me, even in my history as emergency room physician or urgent care, or even accepting insurances as a patient walks out the door and we rarely hear from them again, or maybe when they come back. This is a way that we're just starting to roll out, where we can truly monitor someone's progress and see if they're doing better or not. More to come. If you have an interest in that, reach out. And then I will, actually we'll jump to questions, but I'll put this slide right up here. This is my information. And then I'm going to stop sharing my screen here for a second. And if anybody is courageous enough to go on camera, I get to look at you in the eyes. I do have some questions I'll probably jump into here right away. If you have a question, feel free to put it in the chat. It looks, let me just look through here quick. And a couple questions that came through. Here's a good one. Mounjaro, exactly the same as Ozempic and Wegovy, which is actually a repeat of a question that I had previous. Is Ozempic healthier than Mounjaro, and can you be on it forever? I think we answered the second question. Ideally, these medications kind of for the rest of our lives, right? So chronic medications generally are long-term, right? And we will, as humans, invent different ways to utilize these, and again, if someone really changes lifestyle and we utilize the GLPs as a way to accelerate loss, could we get off of them? Theoretically, there are some numbers that push against that, and it is a bit of an experiment as we move forward. Mounjaro is another form of long-acting GLP-1. To be frank, the reason I saw Mounjaro is associated with a little bit more weight loss than semaglutide or Ozempic. The reason we haven't jumped there, one is it's much more difficult to get. Two is, the price, at least that I've seen, has been a little bit higher, and it doesn't have as long of a history of looking at it and safety in humans. Mounjaro and Ozempic are very similar. I call them, brothers and sisters. Mounjaro maybe with slightly more in the few studies I've at weight loss, but we haven't quite embraced it fully because of some of those other issues I mentioned. Good. And then another question I got, when coming off semaglutide, good long-term blood sugar regulator? If not, what is? So metformin is, also something that we utilize efficacious in weight loss, but can be utilized and support weight loss. It also is not associated with the lowering of the blood sugar, which I like about it quite a bit. About a year and a half ago, I did write a blog that metformin is very hot in, longevity or health anti-aging circles as a longevity medicine. Is metformin a good long-term blood sugar regulator if I come off of Ozempic? We don't know, and that's where when someone comes off Ozempic, we have to see how does that impact them. Certainly metformin could be a tool that's utilized expect it. You do have to take it daily, but it could be something to help not only with insulin levels, but also, support weight loss. And it is something that most patients tolerate pretty well. GI side effects, stomach side effects are probably the most common with metformin as well. And then, if not, what is, honestly coming back to lifestyle and really having a plan for lifestyle. I spoke to exercise is probably the most important indicator of us maintaining a healthier weight that we got to. And we use a fair amount of berberine as well. Berberine is a supplement that we see can help decrease insulin. I just recently did a deep dive on plants that have substances that are similar to GLP-1 agonists. So I do expect that we'll see many more of this class coming down the pipeline in the future as well. One other question here, biggest concern is about the side effects, nausea, et cetera, how to handle them. I think this is a great question. And for me, it's like really important. If a patient experiences side effects that really are over the top, we basically remove that medication because a lot of us don't want to go back to it. It's so severe that we don't want to go back to that. So as much as we from the get-go, I think is very important. The most important factor I've found with that is the slow titration. And that's in part, we have our own titration schedule, which is a little bit slower to try to minimize as much as possible those side effects. Other things that patients have used to try to mitigate the gastrointestinal side effects, and these are anecdotal, right? So I won't say that these are proven by the literature, but I do want to share them. And if you read any or speak to any pharmaceutical company, they say use it only as directed and in no other way. So take this with a grain of salt. But some patients have found, most patients will inject into their abdomen. Some have found that injecting into their outer thigh has helped them subjectively with those GI or stomach side effects. We've had a few patients that have actually broken it up. So again, it's tough with the auto injector, but we offer syringes here. You can give half in the morning and then half at night. And some patients have found that splitting that up has also helped them in terms of the side effects. Is it recommended for lifelong? Does the body get used to it? What happens when you stop? So I covered that a little bit earlier. It's recommended for the rest of your life. This is a chronic medication. Preliminary research is showing that if you stop it and don't do anything else, you can potentially regain thirds of what was lost, which is significant. Again, we don't know if somebody does do marked lifestyle changes or supports this weight loss program with an integrative functional approach, how would that change? Those are questions. And then does the body get used to it? Data dating back, about 10 years right now, and there doesn't appear to be that. But again, the story will have to be ironed out with future research. Again, a little bit different question, but since this lecture was just about semaglutide, this is in the event one is admitted to a hospital, do you have access to act as advocate in a preferred natural protocol? I think that's a great question. That's one I've gotten before. I just recently reapplied for privileges. I am assistant clinical professor at Mount Sinai. And the privileges that I get, the majority of outpatient physicians, we don't round in the hospital. And I used to, but it's just, there's been kind of a divide. There are hospitalists that work in the hospital, and there are those of us that work outpatient. My interaction with Sinai is that I can, at least opine and interact with the team on, what might be an optimal treatment for a patient. Generally, hospitals aren't too open to integrative, right, and natural protocols. That's not always true, but generally they're pretty focused on the Western medicine paradigm. But I do find very often, even hospitalists, and I've been a hospitalist myself in my career, are very open to speaking with primary care doctors. There are insights that can help. And so that is certainly something we can do, advocate on your behalf, interact with the team if you are hospitalized, and certainly encourage patients to, and when you are hospitalized, and we're here to support that in any way that we can. Can multiple diabetes medications affect your brain chemistry, causing depression or brain fog or other symptoms? I have not seen that pan out. I think honestly, my biggest concern with some of these newer medications is the impact on the microbiome, or potentially impact on resting metabolic rate, which is a medical term for how many calories are we burning, right? Just by sitting here. And the more that we burn, obviously, the more that's going to support weight loss. And that was the concern of the research from the biggest loser that I mentioned before is that resting metabolic rate decreased because they were under so much stress. And that can fight against us for a long time, because that's just kind of a given burning calories that's happening no matter what we do. So those are probably my two biggest concerns. I have not seen it impact those other things, brain fog, affecting your brain chemistry. I will say that hypoglycemia certainly can. And I mentioned that a little bit before, but sweating, shakiness, kind of even confusion, irritability, I see low blood sugar really kind of mimicking those symptoms that were asked much more than anything. And some of you may have even seen that I'm more and more into even prescribing a continuous glucose monitor. For anyone that's a concern for them, I do think it's a real beneficial tool to actually wear these monitors. It's got a tiny needle and a sticker that can go, either on your belly or your arm. My last look is, around $150 to $200 for a 2-week continuous glucose monitor is a great way to not question how is this impacting my blood sugar, but to actually know. But and then the last question I have here, the question is, how can I get insurance to pay for semaglutide if my A1C is with taking metformin and blood sugar is 100 milligrams while fasting? Does this qualify even though I have not been diagnosed with diabetes? And I'll give a sigh with just insurance. Your guess is as good as mine, just to be frank. There are so many insurances out. I wish I had a great cert. We don't know, right, until we try. And then I just encourage all patients, do as best as you can, right? And I know it's a headache, but to advocate for yourself. My doctor, this is something that will truly benefit my long-term health. Ask both pharmacist and potentially your insurance what is needed for this to be covered. Be adamant about that. Try to collect that, and we are here to support it. Any information that we can give that will increase your chance of it getting covered, we're here to support. But again, we've had such a headache with it, just to be frank. That's where we've gotten to the point where we offer it here, and at a fixed price that no one has to kind of go through that headache. So there are options for this to be a potential treatment. Good. I think those are questions that came in from the listserv and the email. I'm just checking one more time. Great. Yeah. So I have a quick question. Been on Ozempic for a week, haven't had any side effects nor any decrease in appetite and weight. Would it be an option to go to 0.5 for my second week? Again, these are very specific questions. Like I hesitate to answer, here on a specific patient question, but the short answer is probably yes. You should have been given, when you were prescribed, a very specific titration schedule. This is what we're following. Be careful. We feel great, right, until we don't. So if we jump that too quickly and then get hit hard side effects, that can throw us for a spin. And sometimes 2 steps forward, 1 step back is the only thing I would say. But some of us tolerate things better. Some of us are very sensitive to your body. Reach out to your provider and ask, right? And a lot of times we can certainly accelerate the titration schedules, that someone is feeling well and not being negatively impacted by side effects. All right, great. Here is another question about continuous glucose monitor. In relation to the weight loss, are the age right now? Do you recommend them? Who should or should not use them, and what can be learned from using them? I do like them. I do recommend them. I am, for those of you that know me, I'm a fan of data. Like, I like data points, and I think that we have to be able to interpret those well. I think the few cases where maybe isn't for you a continuous glucose monitor, if every reading is making you anxious, right? Oh, is this too low or is this too high? I've certainly had some patients that knowing their data maybe doesn't help as much, and that would be the one kind of caveat I would say to doing that. Obviously you have to be comfortable putting something in. It's a tiny needle, you barely fit it, and there's a mechanism by which to do it. But for me, I think the greatest value, and I don't think we talk about this enough, there were some kind of blanket oasis recommendations for nutrition that there's a lot of debate whether they're good or bad or influenced by corporate America. And one of the biggest things I think many are arguing that was missing there is what's called the glycemic index, right? And the glycemic index is how quickly this food that I eat right now increases blood sugar in my body. So a great example is that, if we take sugar from an apple and just ingest that in a liquid form, the glycemic index is markedly higher than if we get that same sugar in the package of an apple. that has water, that has fiber, that's going to slow the digestion and the increase of that sugar in our blood. And so those foods with lower glycemic index are going to be far better for our long-term health. Basically, those foods that aren't spiking our sugar, which is also spike our insulin. One of the things we're seeing in medicine right now is those blended foods that we thought had a glycemic index, for specific people, it doesn't cause that. Or those that we thought were good, maybe it spikes specific people, it spikes their a little bit more. And I know that's a little bit of a scary thing to say, because, well, what do we know? You know, the most part, for the majority of us, we know high and low, but the beauty of a continuous glucose monitor is I get to do that experiment myself. I get to eat an apple and see where blood sugar goes. Be very fully transparent. When I wore mine, what spiked my glucose the most was Indian food. You know, and Indian food, I love it. I actually really enjoy palak paneer, and I really saw that was what spiked my blood sugar the most. And the reflections are what else to make smart decisions and maybe avoid some in the future. Is having to use meds imply that weight management for some is not just nutrition, exercise, lifestyle, but chemical genetic? Yeah, great question, Suzanne. And I think it's like, you know, so many things, it's somewhere in between, right? And I think I like on one side, and maybe I'm playing Switzerland here, right? What would be the criticism of me, but I like that one, it's not your, you know, like, I'm not saying you, but again, it's not someone's fault that their weight is higher than normal. But I also don't want to take away the power that you also have control, right? I think in medicine, we give, and there's nothing left that I can do for my own health and wellness and even maintain a healthy weight. And we see remarkable loss without medications, and we have for a long time. And I truly believe that it is the combination of these two, you know, that's catered patient in front of me that is the best approach, right? And patients, I may say, hey, hold on that. Like, let's not use that. And oftentimes I like to as a crutch, but you know, even a crutch we throw away. And I'm saying this is long-term, but let's hold off on that, because let's see where you can get with the lifestyle interventions. But I also have many patients that, well, I am just hitting my head against the wall for year after year after year after year. And I need something to break through, you know, this level that I can't get past. This is really a fantastic mechanism, even to instill the confidence that there isn't a level here that I can't get past. And then can we, again, with lifestyle, solidify that new weight in a way that we can maintain it? I hope that answers your question, Suzanne. Great, yeah. How many years of research was done on this medication? I think that's a brilliant question. Because you know, the majority of clinical trials are going to be about 14 weeks, right? Some of them longer. And I do have to admit, I didn't look at the actual duration of the trials that I looked at, but the majority of these are not going, you know, past even 3 months. There is longer term, as I alluded to, post-market surveillance that is required of any FDA medication, that we do have to report side effects as physicians. Patients are encouraged to report those. And we do have to monitor long-term if we're getting signals for any of these other things. But that is probably one of my biggest criticisms, right, of an FDA process, is that it is relatively short. And modern medicine is focused on something very efficacious, very quickly, very strong, that it can pass those barriers required for an FDA approval. But after that, there isn't as much concern, just to be very honest. So that is, in terms of, I put on that slide, kind of the long-term effects. This is something that takes a really long time to see, and a tremendous money to follow somebody for many years on a drug that, again, many of our pharmaceuticals won't go through that length to do so unless it's a blockbuster drug. I certainly hope that that continues with semaglutide and we get better and more information. And I think that's a good setup for me to say too, that, you know, even what I'm talking about right now, I've learned a ton in 6 weeks, which I learned a ton in 6 weeks prior to that. So these things are moving quickly, they're changing quickly, and is in part why I love to have these things. Let's at least share what we know at this point, and even what we're knowing is evolving very quickly. And that's where it's good to ask questions and to try to follow literature, at least check in with your doctor or provider if there are questions about these. Good. I think I answered everything here. Any other last questions before we wrap? All right, I will take your silence as a no. I really appreciate everyone for joining. I know everyone has a super busy schedule. I hope that this was helpful. We did record it for anybody that wasn't present, and we will do so in the future too. Not that we don't want to encourage in-person attendance, because I love to see the face. It's me. When talking to all of you, it's much easier than speaking to a computer. This will be recorded and shared, and we certainly hope to do more in the future. If you have a topic you would like, send us an email, and you should know how to get a hold of us, info@cbeyondmedicine.com. And we are here, to answer those questions. Docere means to teach, right? The word doctor comes from that. Thank you for all attending, and I hope you learned something, and we'll be in touch.